Have you seen the Red Wedding episode of Game of Thrones? Well, I'm about to show you one of the ways in which value-based contracts can lead to complete annihilation of independent practices. The Red Wedding nightmare of value-based care. Now, in my last couple of videos, I used my value-based contract simulation model to show you why most ACOs fail and why most independent doctors, they sell out to large healthcare organizations. And if you've not played with the model yet, you can find it on vbcsim.pcplens.com. In this video, I'll show you why even generous offers from insurance companies, and I know that sounds weird, to help fund doctors to set up an ACO to reduce the total cost of care can lead to a red wedding outcome. Let's dive in. Okay, so when you first go to the webpage vbcsim.pcplens.com, this is what you're going to see. And there are 7 steps in this model, all the way from setup to a Monte Carlo simulation. So we're going to go through the first step. And again, I'm going to run through the first few steps because I've covered them a couple of times in my previous couple of videos. And if you've not watched at least the first video on the financial simulation model, I'd strongly encourage you to watch that one because it goes into detail about how all the mechanics in the simulation works. So let's jump in. The first step is configure the ACO, and as usual, we are going to be following the realistic scenario. Our network size is about 100 PCPs. We have about 1,000 patients per PCP and an attribution of about 80%. Each patient costs about $10,000. We are going to target a savings of 5%, and a minimum savings rate is going to be 1.5%. And the ACO gain share is going to be 50%. So the payer is going to keep 50% and the ACO is going to get the other 50%. And we have the quality metrics and we have the risk adjustment factor, but we're going to skip that for now. We'll go see the opportunity. When you calculate everything out for the attributed total cost of care is about $800 million in this case. 5% savings is $40 million. So if the ACO does end up saving the 5%, they'll get 50% of this $40 million, which is about $20 million. And each doctor PCP has a potential payout of approximately $200,000. So that sounds really good in theory. So let's go ahead and see what happens. Of course, the first thing is we need infrastructure. So you end up spending a lot of money for infrastructure. And then also you have the per PCP burden. You're participating in a value-based care contract, and that comes with a lot of administrative tasks that are non-billable. Plus, you also need to hire extra staff to be able to take care of some of the administrative tasks that are thrown at you under value-based care. So when you look at all of that, you need approximately $2.1 million in 1 year to run the ACO, and approximately $57,000 or $58,000 in PCP administrative costs. Because of claims lag, by the time the ACO finances are finalized, it's about 18 months. And for those 18 months, and you need approximately $3.1 million, and the PCP burden has gone up to approximately $86,000. And so for this, at least for this $3.1 million, you need a funder. This is where we will now select option C, payer advance or prospective PMPM. PMPM stands for per member per month. So why does the payer do this? Well, payers have a vested interest, especially Medicare Advantage payers. If the ACO reduces the total cost of care and increases the risk adjustment, the payers can prove to Medicare, CMS, that look, our patients are very sick and this is the expected total cost of care. By the way, we came in way below the benchmark, so you owe us a lot of money. And then the Medicare Advantage plan will take a portion of that money and will give it to the ACO. And the ACO will keep some of it and will give some of it to the physicians. So that's how the chain works. CMS sets the benchmark for the Medicare Advantage plan. Medicare Advantage sets that benchmark in quality for the ACO, and the money flows all the way down. So the payers have a vested interest in funding an ACO because they want to capture more money from CMS. So that is why they will invest in an ACO. So in our case, we've taken the PMPM advance, so the payers will say, we will give you $10 per patient to set up your ACO and to really reduce the total cost of care. But they will also come back and say, we're giving you this much money, but if we'll claw back a portion of it. So essentially, if you end up saving $20 million, 75%, or actually $7.50 of this $10, we will take out from any shared savings that you achieve. Oh, and by the way, there is a ratchet of about 75%. We're only giving you this money for the first year so you can set up an ACO, save money, and then you can use that for your operations going forward. So that's kind of the theory behind why the payers are interested, especially the Medicare Advantage plans are interested in supporting ACOs and setting them up to reduce the total cost of care. So if you look at it, so $10 per member per month is about 80,000 attributed patients. So $800,000 per month the payer is willing to invest in the ACO, which comes out to be for 18 months is approximately $14.4 million. A lot of money that the payers are investing to get the ACO up and running. And that sounds great. The payers are interested, the ACO is all gaga, we got so much money from the payers, let's go, let's do this. So what happens? And there we go and see the outcomes. So let's first see what happens if the ACO hits the target and ends up saving approximately 5%. So 5% is approximately $40 million. The ACO will end up getting or should be getting $20 million. But let's see how much of that actually reaches the physicians. So of the $20 million, the ACO is going to keep approximately $2.1 million. They're going to keep another $2 million for reserves in case they lose money the following year. But here's what happens. The payer is going to take out approximately $9.6 million from this $20 million that was supposed to go to the ACO. Why $9.6 million? Remember, they were paying $800,000 per member per month, $10 per attributed patients, and we had 8,000 patients, so that's about $800,000 per month. Multiplied by 12, you get approximately $9.6 million. So by the time the money that is supposed to get to primary care physicians, what's left of it is just $6.3 million. Divide that by 100 primary care physicians, it's $63,000. And again, $63,000 looks great. That seems like a lot of money per year to be giving out to primary care physicians. But remember, this money is coming after 18 months. By that time, the practice burden is $86,000. So even though primary care physicians received $63,000 in a bonus income, they still ended up losing approximately $23,000. These are the mechanics which a lot of people don't understand. They look at it like, oh my God, like we just came out to you with a $60,000 check. Why aren't you happy? Well, you don't realize the amount of time and energy that went in to earn that $63,000 was way more. If we would have just seen patients, that would have done two things. As primary care physicians, you would have probably earned more. Second, more access. Patients can get in sooner. They can get the care that they need. So it's paradoxical. Primary care physicians are losing money and patients have poor access because we're spending more time trying to take care of all of this administrative work that comes with value-based care. So this is a huge problem. Even when you win in value-based care, a lot of times you still don't win. Now this is the best case scenario in this case. Let's look at the red wedding scenario. And that happens when you miss your, hitting the total cost of care. You get a payout of $0. The 18-month clawback that the payer invested, they were giving you $14.4 million for 18 months. 75% of that is $10.8 million, which the payers are going to take back. Per PCP take back is approximately $108,000. And when you count that with the practice burden of another $86,000, that is a total of $194,000 that PCPs are in the hole. Imagine that. You went from making a profit of $200,000 to almost losing $200,000. That is enough to destroy the vast majority of primary care practices. This is your red wedding scenario. And this is not happening to a single practice. This is happening to all the practices in that ACO. So what happens? A hospital system or a payer or somebody is going to come in and buy at all of these practices en masse for cheap. And now you have like a highly consolidated system. This is a huge, huge problem. Even though the payers are being generous, they're giving the 0% loan to the practices in the hope that the ACO is going to save money and they're going to get more money from CMS. But because of social determinants of health, for whatever reason, if you don't hit that, almost all the practices get destroyed. So now you see why this is a huge problem, even when the payers are generous and trying to give money for the ACOs to succeed. let's project this forward with the same methodology. And we are going to project it approximately 10 years. The ACO is going to fail within 9 years. That's assuming that they keep hitting the targets and saving money for several years, but because of benchmark ratcheting, they'll end up failing in 9 years. Let's move to Monte Carlo simulation, because a lot of you might be like, well, Dr. Bansal, Sudeep, you just chose the parameters to make the ACO fail, right? And that's a fair point. Let's randomize it and let's see what the outcomes are. We're going to still follow the realistic scenario. We're going to do pair advance. We're going to randomize how much money the pairs give us. We're going to randomize the clawback percent, and we're going to randomize the PMPM ratchet. And let's see what happens. I'm going to scroll down, and I'm going to, for the year one, I'm going to run the simulation. Now, we've already set up in year one for the simulation to succeed, because we're modeling out in year one, the ACO is going to hit 5% savings. So it's unsurprising that the ACO rate is going to be 100% at this time. But remember, ACO is still getting money. What we're talking about is how much of that money reaches primary care physicians. So let's look at per PCP net. PCP profit rate, 37.4%. So they lose over 62% of the time. Mean loss is approximately $24,000 per year during the first year. And if you look at the distribution of outcomes, the vast majority of times, primary care physicians end up losing money in the first year. Now let's go to the multi-year simulation and let's run and see what happens. ACO survival rate, 22.4%. The vast majority of time within 10 years, most ACOs are going to fail. Let's look at per PCP net. PCP profit rate, 27%. Mean loss, $106,000 over that time period. Most of these PCPs will end up losing their practices if they lose an average of $106,000 per year during this period. That's a lot of money. And if you look at the distribution of savings, you can look over here. The vast majority of the time, PCPs are going to be losing money when pairs are being generous and offering to jumpstart the ACO, just because of how the incentives are structured. So I hope that analysis made sense. And you can go to vbcsim.pcplens.com and you can play with this model and adjust all the sliders to your liking and play with the outcomes and see what you think. I follow the realistic model because that's kind of what I've seen happen more frequently, but different geographies, different locations might be different, and you can plug in your own values and you can see the survival probability of an ACO. But the entire point that I was trying to make in this is, even when people are trying to help physicians to survive, to try to do better, the way we've ended up structuring the system in value-based care, it still leads to bad outcomes. Even when you have people who are trying to do the right thing, the system is fighting against you in order to do the right thing. This is the underlying problem with value-based care, which is why it will eventually lead to consolidation. It is a scale game. You cannot survive by yourself. And as more and more health systems keep getting consolidated, it will lead to higher cost of care. So paradoxically, when people think that value-based care is going to reduce the cost of care, that's not actually what's going to happen. Paradoxically, it is increasing the total cost of care. So with that, take care and goodbye.